Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream. Ask me anything, life support decisions, ICU decisions, tracheostomy decisions and intensive care at home decisions. Ask me anything. This is your opportunity to talk to me directly and have your questions answered. My name is Patrick Hutzel and I'm the host of this YouTube live stream and the show. What makes me qualified to host the show? Ask me anything about life support in intensive care, ICU decisions, tracheostomy decisions, intensive care at home decisions. Well, I'm glad you've asked. I am a critical care nurse by background, having worked in critical care nursing for over 25 years in 3 different countries. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com, and that's also how long we've been operating at intensivecareathome.com. As a matter of fact, with Intensive Care at Home, we even started 12 months earlier in 2012. So I come with a wealth of knowledge, and that's all documented on my intensivecarehotline.com blog, as well as on the intensivecareathome.com website, where I publish regular content about both intensive care as well as intensive care at home. Now, and you can also look up our testimonials on both websites at intensivecarehotline.com and also at intensivecareathome.com, because I can confidently say here that we have saved many lives with our consulting and advocacy, as well as with our intensivecareathome.com service, nursing service at home, where we provide a genuine alternative to a long-term stay in intensive care. We're cutting the costs of an intensive care bed by around 50%, and we are bringing the intensive care into someone's home, providing much improved quality of life, and in some instances quality of end of life for our clients and their families. Now, I also want to welcome our viewers on replay, because I know these videos are getting watched on replay if you couldn't make it to the live stream. But obviously, if you can make it to the live stream, this is your opportunity to ask your questions directly to me. Type them into the chat pad or click on the StreamYard link and talk to me directly here. Like I said, have a look on our testimonial sections. You can also look up our intensivecarehotline.com podcast section, where we have done client interviews. Now, we are usually going for about an hour, and I want to welcome everyone, whether you're in Australia, in the US, in the UK, Canada, India, South Africa, wherever you are. I welcome each and every one of you. Also, if you find value in those videos, click the like button, share the video with anyone that you think will benefit from these videos. Subscribe to my YouTube channel, of course, and spread the word of what we're doing here for anyone that will benefit from our message here. Now, today I want to start with a couple of local intensive care at home topics. One topic is that, we were working with a client actually for many years, a client with a advanced progressive disability that required her to be on BiPAP. As a matter of fact, she had myasthenia gravis, and she was a local client here in Victoria in Australia, and she was on BiPAP on and off as part of her myasthenia gravis. She was initially NDIS funded for 24-hour nursing care, which she obviously needed. She had a long-standing medical history, and she needed 24-hour critical care nursing at home, as otherwise she would have been in ICU. Now that worked up until the end of April, early May this year, until the NDIS decided, in spite of overwhelming medical evidence and disability evidence, to cease funding for nursing care. That is in spite of independent nursing assessments by legal nurse consultants with a critical care nursing background. And the minute the funding went down, we obviously had to stop working with this client. And I then informed the NDIS Quality and Safety Commission, highlighting to them that without reinstating the funding, that this particular client will be at high risk of dying. Unfortunately, we found out last week that she passed away just as we predicted. It is another client where the NDIS, I believe, is directly responsible for a patient death. That came after last year as well, where we highlighted a similar situation with the NDIS Quality and Safety Commission. The same happened. So it does keep happening, unfortunately, and we will continue to talk about it here because it needs to stop. People are dying, and it absolutely needs to stop. Now, interestingly enough, I also found an article yesterday that I need to read out today, and I just quickly need to go to my emails. So where is it? There was an article that I found in the news yesterday, a very shocking article because it ties pretty much right in with what I talked about just right now. Oh, there it is. Okay. This is an article that was in the news on the 19th of September, so 2 days ago, on the Daily Mail. Here is what the headline is. I kept my daughter alive for 4 years under a broken NDIS system, but just days after she left my care, she died alone and in a pool of her own vomit. Then the article continues, mother robbed of dignity by NDIS, fought to try and get more care. Government swings axe on NDIS. Those are the sub-headlines. Let me read out the article. A 4-year-old girl died alone in a pool of her own vomit after her family were left to care for her with little support following a cut to her care funding under the National Disability Insurance Scheme. Koa, or Coco as her family affectionately called her, was diagnosed with a rare and incurable neurological condition called lissencephaly, even I can't pronounce it, when she was 5 weeks old. I just typed this medical term in the chat pad actually, so that you can see it. Lissencephaly. She passed away in July 2025 after she caught influenza. She choked on her own vomit while alone in a hospital ward and was pronounced dead a day later. Koa's genetic condition causes severe intellectual and developmental delays, often accompanied by epilepsy, cerebral palsy, and other neurological issues. Many with the diagnosis do not live past the age of 10. Her mother, Alicia Gibson, has accused the NDIS of failing her terminally ill daughter after support for Koa was limited to a nurse just 3 hours a week. Mrs. Gibson said the government service failed to acknowledge the extent of Koa's disabilities, with one pediatrician telling her that if Koa was not deserving of a full-time professional carer, i.e. ICU nurse, No other child in Australia was. From the moment we started asking for help, there was pushback. It didn't matter how much evidence we provided of her disabilities, how many supporting letters, or what we told them. Koa needed to live, Mrs. Gibson told the Daily Mail. Between the ages of 2 and 3 years, Koa's condition worsened, and the full extent of her associated disabilities were revealed as she underwent precocious puberty, the rapid early onset of puberty. Her body doubled in size in 3 months, meaning she required a higher level of care than what she provided in her 12 months plan with the NDIS. Symptoms of cerebral palsy, scoliosis, and respiratory issues became clear to her mother and doctors, but not to the button pushers at the NDIS, Mrs. Gibson says. We must have had about 15 to 20 letters from professionals providing supporting evidence that Koa was not receiving adequate help and she needed more, she said. She went from needing one person to carry her to 3 to 4. A push chair needed to be a standard wheelchair. Her NDIS plan did not suit her. They were evaluating her as a 2-year-old when it should have been as if she was 6 or 7 years old. On May 19th, the NDIS changed how funding is provided to recipients. Now, when a plan is reassessed, participants receive funding in 3-month blocks rather than accessing their 12 months of funding all at once. Koa's 150-hour allocation for nursing equated to less than 3 hours per week. It didn't matter how much we begged, the NDIS still ignored even supporting evidence, and we were overruled, Mrs. Gibson said. So here is the letter that actually Koa's mum sent to the NDIS. It's actually published in the on the Daily Mail article. 14th of June 2025, to whom it may concern. It is so disheartening to find myself writing to the NDIS about the proposed funding plan for Koa Gibson, participant 43, just over a year since the last debacle. It is infuriating that after all the drama and angst of last year's plan review, it appears the same thing is happening all over again. The NDIS have issued a plan proposal that is absolutely unfeasible and obviously shows that the person making the assessment has not read Koa's file and history, nor has any idea about her condition and its impact on her life. Koa suffers from lysencephaly, cerebral palsy, which is level 5, the most profound, severe hypotonia. She cannot hold up her own head nor move her limbs in any purposeful way. She's fully incontinent, plus now a full-time indwelling urinary catheter, multifactorial respiratory compromise including oxygen, and BiPAP respiratory support dependency, atypical and difficult to manage seizures. So let me just stop there before I continue reading. Just the section of urinary catheter, multifactorial respiratory compromise including oxygen and BiPAP respiratory support dependency, as well as atypical and difficult to manage seizures. That in and of itself is enough to warrant a critical care nurse 24 hours a day, funded by the NDIS, because cerebral palsy and lysencephaly are funded NDIS diagnoses. Right? And we have clients with similar diagnoses and similar conditions that are 24-hour nursing funded with critical care nurses through the NDIS. So then the letter to the NDIS from Koa's mum continues. Koa requires hoisting for transfers and transport in an electric wheelchair operated by a carer, has severe hypersalivation and inability to manage secretions requiring very frequent deep suctioning, poor cough, and sputum clearance requiring physiotherapy and deep suctioning. And I just stop there again, because again, that in and of itself is also enough evidence to require a critical care nurse 24 hours a day. Severe hypersalivation and the inability to manage secretions requiring very frequent suctioning, poor cough and sputum clearance requiring physiotherapy and deep suctioning is the indication to require a critical care nurse 24 hours a day. On top of that, what's not in the article, but I can read from the article, she needs a cough assist machine, which also is the skill of a critical care nurse. So then the article continues. Koa is totally nonverbal and cannot communicate in any meaningful way, requiring full assistance with all activities of daily living and precocious puberty, early onset, requiring a medication that causes brittle bones. This means that Koa's disability affects nearly every system of her body. The management of all these issues requires a very high level of medical care that simply cannot safely be met by carers, even if they have had, quote, and she puts in quotes, high acuity training. And this is what I've been saying on this podcast for many years when it comes to intensive care patients at home. This cannot be managed by support workers or disability support workers or by carers. That is like flying the airplane with a cabin crew instead of the pilot. And we know what happens then. People have died, and I've said it on this podcast many times, and now another person has died. It is unbelievable. It is outrageous, and the NDIS needs to be called out for it. Because it looks like there is overwhelming evidence for the need of a critical care nurse, and this little girl has passed away. So then the article continues. So what I just read out is Mrs. Gibson, Koa's mum, outlined Koa's additional disabilities as they became evident in urgent letters to the NDIS, including the email pictured above, or the email that I just read out. Also keep in mind, not even a general registered nurse without ICU experience is qualified to look after patients like Koa. Now, she was on oxygen 24/7, a BiPAP ventilator, suffered 8-hour-long seizures each day and needed up to 60 medications a day. Now, medication management is also something that can only be done by registered nurses, not by disability support workers. Mrs. Gibson said her mental health suffered while caring for Koa on her own. I was doing a doctor's and nurses and ICU's nurse's job in my home by myself without qualifications. My mental health was at rock bottom. I wanted to die, she said. The NDIS didn't care. I put in a letter that I wanted to die and nothing changed. Koa's mum, Mrs. Gibson, begged the NDIS to release the rest of Koa's funds ahead of winter, knowing it was the most dangerous season for at-risk patients. Noah's mum tried to negotiate, asking if all of Koa's funding could be released in the place of 24/7 nursing, which she was in the process of trying to secure. Despite other cases of leniency, the NDIS refused. Then Mrs. Gibson became unwell. In June, I caught influenza as Koa's primary caregiver, and I knew I was going to kill her. I had nurses volunteer their time because they knew if Koa would catch the influenza, she would die, she recalled. The NDIS didn't leave me any space to get sick. They do not account for life. Koa did catch her mother's flu and was rushed to hospital on July the 7th, where one nurse is typically in charge of 4 cases. On July the 10th, she vomited medication into her respiration mask, a known risk with her condition, which requires immediate suctioning. Alone on the ward, Koa began to drown in her own vomit. The little girl was pronounced dead the following day. This is absolutely horrible and heartbreaking. And just on that note, this is the risk for someone on BiPAP with seizures, right? They're at high risk of vomiting, they're at high risk of aspiration, and this is exactly what's happened here. This is exactly the justification for critical care nurse 24 hours a day, because this is the risk, what can happen in situations like that for those clients. Koa's mum continues, said Mrs. Gibson said the loss was difficult to overcome, but the indignity Koa and her family had suffered was entirely unjust. When someone passes, it's outside of anyone's control, but the NDIS could have made my life easier, could have granted me quality time, she said. We live in a first world country, we should be looking after Australians. Just because they're disabled doesn't mean they are less than able-bodied people. Mrs. Gibson said she cried for hours after losing Koa, her eldest daughter. I wanted to die at the hands of our own government. I can only imagine what it's like in the shoes of a disabled person, she said. Koa's gone, but I want accountability from the NDIS, whether it's lifting funding blocks for other Australians like me. They need to get in touch with the actual disability community. The disabled community is only ever asking for enough to stay alive. She said even the most removed roles in the NDIS should be required to have contact with the real people impacted by their policies. An NDIS spokesman said the service extended their condolences to the Gibson family. We express our deepest condolences to the family and friends of Koa Gibson, he told Daily Mail in a statement. The NDIS provides disability-related support. It was designed to complement, not replace, mainstream services that states and territories provide, such as the health system, who the NDIS works with and is best placed to provide medical and palliative care. This is to ensure the best services are provided to meet the disability and health needs related to each person's individual circumstances, and that participants access the right mix of disability and healthcare supports. The NDIS has and always will assess all relevant information received from participants and allied health teams when making decisions in line with the NDIS Act. And that's how the article concludes. Now, I will say that from my extensive experience, the NDIS has to fund health-related supports when it comes to disabilities, as long as the health issues are related to the disability, which it clearly is in this situation. But maybe Koa's mum didn't get the right evidence. I don't know. I haven't seen any evidence. You know, usually a nursing assessment from a critical care nurse is needed in situations like that. Right? I also want to read out what prompted me to read this article, because I found the article actually on LinkedIn, and just need to find the article now on LinkedIn. Just give me 1 second. Here it is. From Dr. George Talaporos. He's a quite prominent podcaster for NDIS topics. He's got a podcast, NDIS Insights with Dr. George. So Dr. George writes on LinkedIn, Koa's death could have been prevented. She lived with a rare neurological condition and needed complex 24/7 care. In May, the NDIA introduced short and inflexible funding periods, releasing funding in 1-month blocks for home and living supports instead of the full 12 months. Her mother, Alicia, realized how dangerous this was for her daughter and asked the NDIA to release all of Koa's funding early. The NDIA refused. Then Alicia, Koa's mum, caught influenza. As Koa's primary carer, she knew the risk. The NDIS didn't leave me any space to get sick. They don't account for life. Soon after, Koa caught the flu from her mother, who couldn't take a break from caring for her daughter. On July the 10th, Koa vomited into her mask, a known risk with her condition, but no one came to help her because she was left alone in a hospital ward. She drowned in her own vomit. The next day, she was gone. This tragedy was preventable. I warned the NDIA that inflexible short funding periods for home and living supports would cause serious harm. I met with the NDIS minister and the CEO of the NDIA. I told them families would be unable to respond in a crisis. And here we are. I deeply regret that I did not even push harder. Short funding periods were only ever intended to be used when there is a risk of fraud or a history of misuse. The NDIS Act requires that individual circumstances be considered. The NDI is applying short funding periods across the board to families like Coas who sometimes need extra help to keep their daughter alive. It is cruel and reckless, and it is costing lives. Our lives do not fit neatly into fixed funding periods. Shit happens, and we need the flexibility to draw on more support when we are in crisis. The NDIS must act now. Remove inflexible short funding periods and apply them only in cases of fraud or misuse, in line with the NDIS Act. Enable critical exceptions that unlock full budgets when risk escalates. Allow people when complex needs to use the NDIS funding to keep them safe while in hospital with support workers and nurses, critical care nurses who know them well. To the NDI and the government, please fix this. We must do everything we can to prevent more people dying. Please share COA's story and your own experience of inflexible funding periods. The more these stories are told, the harder it becomes for decision makers to look away. Image description: COA, a young girl lies in a hospital bed wearing a bright polka-dotted dress and connected to medical equipment such as a BiPAP machine, which is attached to a breathing mask. Her mother, Alicia, sits beside her, holding COA tenderly in her arms and clasping her hand. Alicia's face shows deep grief and exhaustion as she comforts her daughter. This is absolutely heartbreaking, and it needs to stop. Please share this story as much as you can. But I also believe that maybe COA's mom and family didn't have the right support system in place with the right NDI support coordinator. Usually, the right NDI support coordinator will make things happen for clients, NDIS participants and their families. And also usually the right NDIS nursing assessment. And if you get a doctor's letter, get a physio assessment, respiratory assessment, get an OT assessment, all of that. The evidence is there. The NDIS can't really refuse, right? Otherwise, we wouldn't exist and we wouldn't be in business. So just keep that in mind as well. Now, I will share the link to this article as well so that you can see it, and because I think it is critically important that people have access to this crucial information. Now, in the meantime, if you have any questions, type them into the chat pad. Alternatively, connect with me live here on the StreamYard link, right? So I'll just quickly share the article. Okay, so apologies for that disruption. Okay, other questions that have come in during the week. I just need to very quickly look at my emails. So, where are we? So, yes, so another topic that I want to talk about is an email that I had this week from Anne-Marie. No, from Tony. Tony says, "Hi Patrick, I'm very concerned about my husband. I had a meeting today with the ICU doctor and ICU staff, including a social worker. The doctor is still saying there's no hope, which I don't believe. The doctor is stating that end of life would be his best option. I've explained to him I would like my husband to have time to heal and wake up from this. I have seen signs that my husband could wake up from this if off sedation and opiates. The doctor says he thinks my husband will die in ICU. I am concerned that the doctors will withhold care and treatment or cause something to make my husband die in there. I don't feel my husband is safe in there. What can I do to protect him? It is obvious they do not want someone in my husband's condition in their ICU. As you're aware, my husband had a cardiac arrest and an anoxic brain injury 7 days ago. He's been off sedation for 5 days and he's off all opiates. What are my options?" From Tony. So, Tony, thank you for reaching out with this really important and also quite distressing question. Unfortunately, what you are experiencing is very common for families in intensive care. Once doctors believe that a patient may not have a quote-unquote meaningful recovery, they often push towards end-of-life care rather than continuing active treatment. Families in intensive care, however, often see improvements, small signs and reasons to continue, and they want to give their loved one time to heal. Now, let's look at this more closely. How can you protect your husband in ICU? You are absolutely right to be concerned about your husband's safety. If the ICU team has already formed the view that there is quote-unquote no hope, the risk is that they may not escalate care if something happens. For example, an infection, low blood pressure, or breathing difficulties. That's why it's crucial for you to document everything in writing. Make clear you want full treatment and escalation of care. Ask for a second opinion inside or outside of ICU, and that's what we can do here for you at intensivecarehotline.com. Insist on clear communication about treatment plans, medications, and any limitations they're putting in place. Be present as much as possible. Families are the best advocates in ICU as long as you work with someone like us here at intensivecarehotline.com, where we can tell you what to do step by step and hold your hand step by step. Also, get access to the medical records now. You need to have access to the medical records so that you can actually compare that what they're doing, is what they're saying and vice versa. Very important. Next, because your husband had a cardiac arrest, you need cardiac diagnostics after cardiac arrest, such as what was the cause of the heart attack and the cardiac arrest? Was there a heart rhythm problem? Is he in a regular heart rhythm? Is he in a sinus rhythm, which is a regular heart rhythm, or is he in an irregular heart rhythm, such as atrial fibrillation or any other irregular heart rhythms? Also, was there potentially a heart attack leading up to the cardiac arrest? Next, has an echocardiogram been done to check his heart function? Have they done an ejection fraction? Right, ejection fraction refers to the contractility of the heart, and the contractility of the heart refers to ejection fraction. Now, if ejection fraction is less than 50%, that could be concerning, right? And if his ejection fraction is poor, are they giving him the right medication for that? What's their plan to reverse that? Right? Next. Has an angiogram been done to check whether he's got blocked arteries? Have they done a 12-lead ECG, and what does it show? Is he on appropriate cardiac medication such as beta blockers, ACE inhibitors, or anticoagulants depending on his condition? If his ejection fraction is poor, is he on medication such as dopamine, dobutamine, milrinone? Has the ICU involved a cardiologist to determine ongoing management? Next, neurological testing after anoxic brain injury. Since your husband has been off sedation and opiates for about 5 days now, the next step is a structured neurological assessment. You should be asking, has he had an EEG, also known as electroencephalogram, to check brain activity and seizure activity? Has he had an MRI scan of the brain or a CT scan of the brain to determine the extent of his injury? Has a neurologist been consulted? What is his Glasgow Coma Scale score and how is it trending daily? Does he show any neurological reflexes such as pupil response, gag reflex, or spontaneous movements? Is he breathing spontaneously on the ventilator or tracheostomy? Next, what are your options? And know that you always have options. ICU teams are very good at pretending they can do whatever they want and you will have no say. Nothing could be further from the truth. The minute you challenge, you will see that the dynamics are changing in your hand, in your favor, and you will also realize that the minute you challenge on a professional level, i.e. with ICU insights that I can give you, you will see the dynamics change in your favor in no time. So your options are, of course, continue treatment in ICU. Make it clear you want your husband to stay in ICU as long as he needs. Transfer to another ICU or hospital. If you've lost trust in the current team, you can ask for a transfer to another ICU. And that's also why you need to get access to the medical records, because once you have access to the medical records, you can share them with other ICUs. And of course, get independent advocacy like you get here at intensivecarehotline.com. Having someone like us at intensivecarehotline.com speak directly with the doctors and nurses on your behalf often changes the dynamics immediately. So Tony, your husband deserves time and the right assessment before anyone can make any determination about his future. Cardiac arrest and anoxic brain injury outcomes vary widely, and recovery can take weeks or even months. You're right not to give up after only 7 days. Always remember, time, treatment, and proper diagnostics are your husband's best allies right now. Also find out if your husband's liver and kidneys are working, right? Because if kidneys and liver are not working, that could also delay your husband waking up, right? Yes, opiates and sedatives should be out of his body system by now, but only if kidneys and liver are working. If kidneys and liver are impaired, opiates and sedatives might not be out of the body system and could delay him waking up, right? Very simple. So ask better questions. Ask better questions. Now, another question that I had that we get quite frequently at intensivecarehotline.com is, why do critically ill patients in intensive care need tracheostomy, right? And it's such a common and important question I get from families every day. When your loved one has been critically ill, ventilated and unable to come off the breathing tube, the ICU team will often recommend a tracheostomy. But why? A tracheostomy is usually considered if your loved one has been ventilated for 7 to 14 days and still cannot be weaned off the breathing tube and the ventilator. The reasons for that can be prolonged ventilation needs. Your critically ill loved one might need ongoing ventilator support beyond the usual time frame. Difficulty in weaning. Sometimes patients can't tolerate coming off the ventilator because of weak lungs, weak muscles, or critical illness. Polyneuropathy, myopathy. Airway protection. If your loved one can't manage their secretions or swallow safely, tracheostomy makes airway management safer. Next, patient comfort. Compared to an endotracheal tube in the mouth or nose, tracheostomy is more comfortable long-term making it easier to communicate and sometimes to eat and drink once stable. Also, it can facilitate ICU step down. In some countries, like the US, ICU's push for tracheostomy is to push patients out to LTAC, long-term acute care facilities, or rehabilitation facilities. And I can tell you that's not a good idea. If you are in the US and you're watching this, it's not a good idea to do a tracheostomy for the sake of sending your loved one to an LTAC or to a rehab facility. I've made a video maybe a year ago or 2 years ago with the title 10 Reasons Why LTACs in the United States Are a Scam. And you will find that video if you type that into YouTube or on our website or into Google, you will find that video. And I am not opposed to tracheostomies in general. I am in favor of tracheostomies being done for the right patient at the right time in the right place. That's a good thing. I am not in favor of a tracheostomy being pushed to get patients out of ICU prematurely and have them die in an LTAC, right? Now, sometimes you must be aware that ICU teams can rush families into consenting for tracheostomy without explaining all the implications. For example, questions you should be asking. Will your critically ill loved one be able to wean off the ventilator? And what are the timelines, if yes? What are the chances of recovery with or without a tracheostomy? Is the ICU pushing for it because of bed management and discharge pressures rather than patient outcomes? That's why it's absolutely critical you ask the right questions before making a decision. You need to understand the clinical reasons as well as the hospital's motives. So, also, once a tracheostomy has been done and the patient can't be weaned off the ventilator and the tracheostomy, consider intensive care at home, of course, and go and check out intensivecareathome.com for more information. So, then, following on from, why does your loved one need a tracheostomy in intensive care? I want to move on to the next topic, which ties right in with the previous topic, which is I want to tell you the top 10 questions to ask before you give consent to a tracheostomy. So, it is also one of the most common questions I get from families in intensive care, and it usually comes up when your loved one has been ventilated for more than 7 to 14 days, and the ICU is, or might suggest, or might even push for tracheostomy. They might push for end of life. And when they push for end of life, and you don't know any better, you don't even know that a tracheostomy might be a solution to your loved one's problems. I see that all the time. And ICUs are not being transparent that a tracheostomy is actually an option to prolong life. But before you agree, you need to ask the right question. So too many families are either pressured into a tracheostomy without fully understanding the implications, or they're not being offered a tracheostomy at all if ICU wants to limit treatment. So that's why I'm going to give you the top 10 questions you must ask the ICU team before saying yes to a tracheostomy. So the top 10 questions to ask before a tracheostomy in intensive care. Number 1, why exactly is my loved one not coming off the ventilator? Is it weak lungs, muscle weakness, sedation, or neurological reasons? You have to also ask, is the ICU doing everything beyond the shadow of a doubt to get your loved one off the ventilator and the breathing tube? And I've made an article about how to wean a critically ill patient off the ventilator and the breathing tube, and I strongly encourage you to watch the video or read the article, right? Number 2, what are the chances my loved one can be weaned off the ventilator with or without a tracheostomy? You need numbers, you need a weaning plan, not vague answers. You also need to ask here, is the ICU doing everything beyond the shadow of a doubt to avoid your loved one having a tracheostomy and being weaned off the ventilator and the breathing tube? Number 3, how long do you expect my loved one to need the tracheostomy and the ventilator? Is it temporary? Is it long term? And number 4, what are the risks of not doing a tracheostomy right now? Is it truly urgent, or is the ICU just pushing? For example, the cutoff time for doing a tracheostomy is usually sort of 7 to 14 days after a patient has been in ICU. But think about this. Let's just say you are at day 14 with your loved one. And it's very likely that your loved one just needs another 2 days to get off the ventilator and the breathing tube, right? So why not wait another 2 days? As long as the signs are there. Then, number 3, how long do you expect my loved one to need the tracheostomy and the ventilator? Is it temporary? Is it long term? If it's temporary, what are the timelines to wean my loved one off the ventilator and the tracheostomy? If it's long term, what are the timelines? Is intensive care at home an option, especially if it's long term? Number 4, what are the risks of not doing a tracheostomy right now? Is it truly urgent, or is the ICU just pushing? Number 5, what are the risks and complications of the tracheostomy itself? Bleeding, infection, airway issues. Is the risk of doing the tracheostomy? The benefits are obviously the prolongation of life, a better chance of weaning off the ventilator if your loved one hasn't been able to wean off the ventilator right now, right? Other benefits are, patient comfort. It's easier to mobilize your loved one, and your loved one needs to get mobilized. Number 6, how will a tracheostomy impact quality of life and recovery? Will it help with patient comfort, communication, and eating down the line? Number 7, is the ICU recommending tracheostomy for my loved one's benefit or for bed management and discharge planning? ICUs often want to move patients to LTACs or rehab facilities quickly in the United States in particular, right? And also, obviously, is it for your loved one's benefit? If they want to move your loved one to hospice or end of life, then a tracheostomy is absolutely for your loved one's benefit, right? But you still bring it back to basics, which is, can your loved one have, or what's the ICU team doing beyond the shadow of a doubt to move towards extubation and the removal of the breathing tube? And what are they doing beyond the shadow of a doubt to avoid the tracheostomy? Number 8, what are the alternatives to a tracheostomy? Can my loved one be given more time with the breathing tube, or is there another option? Other options would be BiPAP, CPAP, would be high flow nasal prongs, would be mobilization, cough assist. Those would be alternatives. Number 9, if my loved one has a tracheostomy, who will manage the tracheostomy after ICU? Will my loved one go to LTAC rehab nursing home if you're in the US? Or can they go home with the right support, such as with intensive care at home? And I know, obviously, from decades worth of experience, intensive care at home is a viable option, but definitely not LTAC or rehab or nursing homes, not viable options. And number 10, what is the long-term prognosis with or without a tracheostomy? Well, if there is no long-term prognosis without a tracheostomy because your loved one is going to die without a tracheostomy, then you probably know the answer here. The bottom line is this: a tracheostomy can be life-saving and improve comfort for patients needing prolonged ventilation, but it can also be the first step in your loved one being warehoused in long-term care or ICUs if you don't ask the right questions and if intensive care at home is not available. That's why you need to be in control of the decision, not the ICU team. Also, when your loved one needs a tracheostomy, the question is how quickly can they be liberated from the ventilator? And they might down the line be liberated from the ventilator. However, they might need the tracheostomy in the long run, right? So, yes, so you need to ask the right questions. Need to ask the right questions. So, tracheostomy, good thing for the right patient at the right time in the right place with a plan going forward. The best way forward is always to avoid the tracheostomy and have your loved one removed from the ventilator and the breathing tube, ideally within less than 2 weeks. That would be the ideal scenario. Okay, so if you have any questions, please type them into the chat pad, or alternatively connect with me live here on the StreamYard link. If you have any questions, regardless, if you're watching this on replay, you can reach out to us at intensivecarehotline.com. Just call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. You can also schedule a call with me by clicking on the yellow button on the top of the website by schedule an appointment. Now, next question that's coming from Anne-Marie. Hi, Patrick. My father is now on a trach collar. The hospital probably doesn't want to trach collar if hemoglobin is under 7. Do you have any thoughts? Now, just for context, this is from John. Just for context, John's father has had multiple strokes. He has intermittent seizures and a PEG tube. So, John, it's a great and very important question that most families in intensive care wouldn't even ask, because they wouldn't understand it. They're not asking the right questions, but it's a great question. Your father has had multiple strokes, intermittent seizures, and a PEG tube, which means he's very complex and vulnerable in intensive care. Let's break this down. What is a trach collar? Trach collar or tracheostomy collar trials is when a patient with the tracheostomy is taken off the ventilator and allowed to breathe through a trach mask and or humidified oxygen. This is a critical step in weaning and assessing whether your father can breathe without the ventilator. So why does hemoglobin matter? Hemoglobin carries oxygen in the blood. If hemoglobin is very low, usually under 7 grams per deciliter, oxygen delivery to vital organs like the brain, heart, and kidneys becomes compromised. In patients with multiple strokes and seizures, low hemoglobin can worsen brain oxygenation, increase fatigue, and make stressful trach collaring more difficult or even unsafe. Let's look at ICU practice around hemoglobin and trach collaring. Most ICUs aim to transfuse blood if hemoglobin drops below 7 grams per deciliter, especially if the patient is symptomatic, unstable, or struggling with weaning. Some patients may tolerate levels below 7, but in your father's situation, with his neurological issues and PEG dependence, it's a very fine balance. Hospitals are often reluctant to start trach collaring on patients with low hemoglobin because the risk of failure and setbacks is higher. So what does all of that mean for your father? Team may want to optimize hemoglobin with blood transfusions if needed before further tracheostomy collar trials. Of course, oxygen level monitoring is important. Heart rate and seizure activity closely during trials is essential. Patience is key in situations like that. Rushing trach collar trials with low hemoglobin could increase the risk of setbacks and complications. So in summary, John, yes, absolutely. Hemoglobin plays a huge role in the success of trach collaring. You should ask the ICU team what's his current hemoglobin trend. Do they plan to transfuse before more tracheostomy collar trials? How are they monitoring him during tracheostomy collaring trials? Are they taking bloods daily? Always remember, hospitals tend to look at the numbers, but you and your family need to advocate for what's in your father's best interest and make sure he's set up for success in weaning. Right? Also, another important point here is, it is also more difficult to mobilize your dad if he has a low hemoglobin because he simply might be too weak. right? And if he's too weak, he'll also struggle in weaning off the tracheostomy. So I'm going to wrap this up in a minute here. If you like my videos here, if you find value in them, like them, give them a like, subscribe to my YouTube channel, and share the video with anyone that can benefit from these videos, anyone that has a family member in intensive care or needs intensive care at home. I do these YouTube lives once a week around the same time, 10:30 a.m. Sydney, Melbourne time in Australia, which currently is 8:30 p.m. US Eastern Standard Time on a Saturday night, which is 5:30 p.m. Pacific time on a Saturday afternoon. Now, that will change in a couple of weeks when we go into daylight saving here. Then the time here still will be 10:30 a.m. on a Sunday morning, but it'll be at an earlier time, an hour earlier in the US and North America. Now, with intensive care at home, we provide obviously intensive care at home, a genuine alternative to a long-term stay in intensive care. And we are providing this service to NDIS participants, TAC in Victoria, DVA all around the country, and anybody, that to any hospital, of course, as well, hospital in the home services. We are third-party accredited for intensive care at home nursing. We also have our own intensive care consultant working with us. We also provide NDIS support coordination and NDIS specialist support coordination. Also, we provide TAC case management and WorkSafe case management in Victoria, and any other WorkSafe or TAC client outside of Victoria, but it's under WorkSafe or TAC in Victoria. Furthermore, we're currently hiring for staff in Melbourne, Sydney, Brisbane, also in country Victoria, such as Colac, Wailangta, Bendigo, Leongatha, as well as Melbourne Metro, also in Albury, Wodonga, on the New South Wales and Victorian border. With Intensive Care Hotline, if you have a family member in intensive care and you need help with consulting and advocacy, we can help you at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com with your questions. I also offer one-on-one consulting and advocacy for families in intensive care. And we have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. Thank you for watching, and I will talk to you again this week. Have a look out for my quick tip videos, and I'll see you again next week here in the same forum. Take care for now.